You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. Denard, welcome to the Nailed It Ortho Podcast. Happy to have you on. So welcome to the podcast.
Thanks for having me.
Yeah, I'm hoping we can talk some good things about rotator cuff repair and really dive into the surgical techniques of how we kind of treat these. But at the beginning of our podcast, what we'd like to do is just get a little background, just get to know you a little bit better. And then we can go ahead and hop into the topic in a bit. But, I guess just to give listeners a little bit of background, what kind of made you or drove you towards this, the specialty of, sports and doing mostly shoulder, elbow cases?
Yeah, I mean, in residency, I really liked the idea of being able to be an expert in one area, but still have diversity of what you're doing. So for shoulder in particular, I really liked I was in love with arthroscopy in general, but I liked being able to cover all the bases, right? Arthroplasty, fracture, etc. So I think that's what made me choose it more over sports per se, is really the diversity of what you get to treat and be able to still be, an expert in the area. So.
Right. And looking back at it now, is there any advice, that you would give yourself? Because we have a lot of residents and, fellows that listen to this and some people that are about to maybe start into practice. Any advice that you would give yourself or give somebody starting off new into practice or into their career from kind of what you've learned over the time?
So many different areas, right? I think that the biggest things, there's still the principles, right? Is asking yourself where you see yourself in 5 years and 10 years, what you want to become. And then if you, once you establish that, you can routinely ask yourself the question of, okay, so for me, I said, I want to be an expert in the shoulder. And so for me, and initially that was actually backing up. I wanted to be an expert in orthopedics. I just wanted to do really well and get a good fellowship. So I wanted to do well in my OIT. So I read a paper every day when I was walking around residency. And then that shifted into when I knew I was going to go on shoulder. I was like, okay, I want to be really good at shoulder. And so I would read all the time. And, that just added up. So the point being that it's hard to know sometimes, I think, to exactly how it's all going to end up. But if you have the idea, concept of who you want to be or what contribution you think you want to make, then if you back up and ask yourself, what would that person sort of do? You start to establish habits that lead to things over time. So I have to give a talk coming up about how I established a private practice and a private academic practice in a small town in Oregon, right? And as I look back at it, it's really, there's just all these steps along the way that added up. But throughout, I was just trying to hold to this principle of making somebody who was an expert made a contribution to its shoulder. So I'm not, I don't know if that answers it, but
no, that helps out. It helps out a lot. And one day I hope to get to the point where I'm reading a paper a day in residency. I haven't, but I need to. I try to do some type of reading, but I think that's a great idea for anybody that's listening and starting residency or in residency. Would be just to kind of get at least some type of knowledge, orthopedic knowledge every day.
Yeah, you got to have a background.
Yeah, very true. And the last question I have for you is, we talk about orthopedics a lot, but do you have any interests outside of the field of orthopedics? It can be anything with kids or sporting or cars, family, whatever.
Yeah, it's all family for me right now. I have an 11-year-old and a 14-year-old. So, when I'm not practicing and doing my research, I'm completely spending time with them right now. We love skiing in the winter, doing some, traveling in the summer, but coaching my kids soccer. So that's 6 months out of the year here. So, yeah.
Oh, that's awesome.
Ages.
I tried skiing for the first time last year, and going down the hill was fine, but stopping was a little hard for me.
Yeah. I taught them both how to ski when they were 3 years old each, so they're really good.
Oh, that's awesome.
Yeah.
Well, I guess we can transition into today's topic and talk a little bit more about kind of rotator cuff repair, and we'll get into nitty gritty. But just, just kind of giving a little bit of background first. What's the, I guess, some important anatomy to know about this? Because we'll read and you'll hear things talking about the rotator cable and the crescent, and you kind of, what is that? And why is it important when I guess we're thinking about repairing the rotator cuff as far as function is concerned?
I mean, I think it's sort of like what we were just talking about, how you get somewhere, right? It really comes down to the principles. So in arthroscopy, you have to see it first. And that's going to be affected by, your fluid control, your visualization, your angle of visualization, where your scope's coming in. But then the anatomy, you got to be, just because the field is clear, you have to know what you're looking at. So, I think that it's really important to have a good understanding of the rotator cuff footprint, understand the cable crescent complex. I think a lot of people do that pretty well. But I think in particular, what's probably missed the most commonly is an understanding of the subscapularis insertion from a rotator cuff standpoint. If you're going to do really high level arthroscopy and massive cuff tears, you need to fix the subscapularis, and a lot of people will miss what's actually going on there still at this point in time, even though we've been talking about that for years. Those tears still often get missed. So
okay, so what would I say? You mentioned a little bit earlier, first thing you got to do is see the tear. And, I've been in some cases where, you see a lot of bleeding and you're trying to figure out what's what. I guess what techniques or tips or tricks or anything have you developed over the years to help you at least start to visualize the cuff when we're talking about the operating room and all these different factors that we can change?
Yeah. So, principles here, I like scoping lateral because the blood pressure is lower. Okay.
Right.
Blood pressure is up, that's a big problem. So just naturally, if somebody lays on their side, their blood pressure is going to be lower, right? Your blood pressure drops when you go to bed versus sitting up. And if you need the anesthesiologist to drop the blood pressure, they can do that more effectively. I like to use a pump. I have colleagues who say they do not use a pump. I usually start with a pump though at 40.
40.
Yeah, and Burkhart used to start at 60 and go up from there. I just found that for me, I can start at 40 and add epi to the bags, and that's pretty effective. One thing is that if most of my patients will get an interscaling nerve block, so that drops their pain levels. If you do not do an interscaling nerve block, you'll find sometimes that your blood pressure will rise a little bit higher right out of the gate. And so, you want to be preemptive about giving them some local anesthetic at the very least if you're going to go without an interscaling nerve block. And there's pluses and minuses in interscaling nerve blocks. If it is a massive tear or a revision tear, I do like to use a single gram IV of TXA. So transient acid, right? Because that will help with your visualization as well. And then the last thing is really about outflow. I don't use outflow. I really just try to limit that because that comes down to turbulence, right? And you get this Bernoulli effect where outflow leads to negative pressure that draws blood out of the vessels. So, I try to limit that as well by just having the assistant keep pressure on the skin. I guess probably really the other last thing is knowing where you're dissecting, because if you're dissecting in the joint, you're not going to run into much of an issue. But as you start to go into the subcoracoid space, as you start to go medial to the coracoid, or as you go subacromial and you go medial to the musculotendinous junction, you're going to run into more vascular areas, and you want to preemptively use electrocautery just to prevent bleeding as opposed to using a shaver. Of course, you need to kind of go back and forth, but it's better to be preemptive. So,
right. And so to kind of recap some of the things you were saying, you saying you control the blood pressure by many ways, but one is going to be just to have them in the lateral position. And then 2 is also with the interscaling block as well. It can help with some pain, things of that sort. And then
Right.
you also mentioned the pump presser. So you start, is 40 the typical? I know I have, I work with attendings that don't use a pump, and I work with some that do. And next time I'm going to pay more attention to the numbers that it's on. But is 40 typically like around there pretty standard for starting their pump pressure?
40 is pretty common. Yeah. I think 60 is on the higher end that you'll hear. Yeah.
Okay.
The one nice thing about a pump too, probably in most cases you can get away with gravity. But a nice thing about a pump is that if you do have a period where you have bleeding, you can typically do a lavage or, a flush, meaning you double the pressure for a short period of time, or it goes up by 50%. So, that's a nice part of a pump that you can't do with a gravity inflow alone.
Oh, okay. Yeah, I've seen that where it'll say pump it up to 15 for a second while you try to get the beater and cauterize it, for example, like you were talking about earlier.
You got it.
And so those are, we're in the case, we see the tear, we can notice it. Can you quickly just kind of touch base on some of these major tear patterns? Looked, and I know there are a couple different ways to, I guess, classify rotator cuff tears, but it seemed like the most common was just kind of just based on their shape. So can you kind of walk us through some of these different shaped tears, and you can talk about, I guess, kind of what you see and anything that makes one different versus the other, like what's the importance of it?
Yeah. So, just, tear pattern is your tear pattern is going to dictate your repair pattern, right? So when we're talking about the superior cuff, supraspinatus, infraspinatus, the mobility of that tear is going to affect how you want to repair it. So crescent shaped tears are typically mobile from medial to lateral. They're going to be typically in the 2 to 3 centimeter size max. They're going to be typically amenable to double row repairs. So basically you pull straight medial to lateral, you get an easy reduction with very little sense of dog ears or mismatch anterior and posterior. Typically on an MRI, you're going to be able to predict those because those tears are going to be less than 3 centimeters in size, both on the AP and the lateral views, so on the coronal and sagittal views. Then you move up to your longitudinal tears, anterior L-shaped tear, reverse L-shaped tear, U-shaped tears. These tears are going to be, because they're longitudinal, they're going to be typically 3 centimeters or greater in one plane, but not in the other plane. So for an example, you might have a tear that's 3 centimeters on the coronal view, but on the sagittal view on the MRI, it's only 2 centimeters. So it's going from front to back. Well, that's going to be an anterior L-shaped tear. These tears are typically more mobile from anterior to posterior, in addition to the side to side. So you're going to have to follow those by reducing. And so first thing you want to reduce is you want to reduce over medial to lateral, but then also assess anterior to posterior mobility, and you'll be able to see the differences. And then lastly, the massive contracted tears are going to be greater than 3 centimeters in size. Both coronal and sagittal views. They're typically going to require interval slides to get mobility. At a minimum, anterior interval slide and continuity and capsular release. We can debate about posterior interval slides. Typically, for chronic tears, these are going to be more single row type of repairs that you're going to be performing because of the limited mobility. But they're going to have rigidity. Both they're going to be less mobile from A to P and from medial to lateral, and they're complete 2 tendon tears.
Okay, so just to kind of summarize, so we have our crescent tears, which you mentioned a little bit earlier, have good medial to lateral mobility, so you'll be able to kind of pull that tissue pretty easily over and do your repair if you're doing a double row versus single row repair. And actually, can you quickly touch base on the difference between single row and double row? I remember as an intern, I kept hearing those and I just didn't want to ask, and I just had to just Google it on my own. But sometimes we have some, interns or second years that are listening to this who may not have done their sports rotation. So what is a single row repair versus a double row repair? And is there any differences between the two?
Yeah, so single row, as the name implies, is just a single row of anchors that goes across from anterior to posterior on the tuberosity. Typically, somebody will place an anchor every centimeter to centimeter and a half. And there's some variance of where those anchors are placed, whether they're placed all the way medial against the head, or if they're placed all the way lateral. But a single row would be one set. Double row would be you have two sets of anchors, where you have a set of anchors along the medial aspect adjacent to the articular margin, and then you have a set of anchors laterally. The traditional double row that was initially described by Lyon and Burkhart was a independent repair where there was two medial anchors that had sutures passed up through the cuff in a mattress fashion, tied down, and then the lateral edge was brought down with simple sutures through the lateral anchors. Everything was tied. Okay. Now we have what are called suture bridging, or some people like to call these transosseous double rows, which means the medial and the lateral rows are linked. And that linking occurs because the lateral anchors are knotless in fashion. So you have sutures that passed up medially, maybe or maybe not, knots are tied, and then they are brought over to lateral anchors to secure the suture limbs down. And that leads to compression of the footprint as you get that fixation. And that compression has a wedging effect, so that when the cuff is pulled medially, you not only get increased contact area and pull out, but you get a wedging effect of the tendon against the tuberosity. So that's, fundamentally. And then there's clinically, what does that lead to? Well, okay, biomechanically, double row is better, as it would make sense. You got more sutures, contact area, pull out strength, etc. When you look at healing is generally better with a double row repair. When you look at functional outcomes, however, the data is often less clear. And that's because our functional outcome data does not always reflect exactly what is going on with healing in terms of how the scoring systems are designed. The other thing that clouds it too is that, I don't want to say that one should do a double row repair for everyone, because some tears are just, as I said, not amenable to a double row repair, and you are over tensioning by doing a double row, and then you can get secondary failure of the cuff. So,
and when you say healing, are those studies where they look at the MRI a year afterwards and see that the cuff is healed? Is that how they typically?
Correct. Yeah. Generally speaking, yes. Yeah.
Okay.
Generally speaking, minimum of 6 months, right?
Right. Okay. And so those are crescent shaped. And then you mentioned kind of our U or our L shape, those kind of right. Bigger tears, 3 centimeters, with 3 centimeters, where it has more A to P mobility. So for right. these, you're saying you can do like a side to side suture or suture.
We'll do side to side at some point, margin convergence to bone. For an anterior L shape, for instance, you'll typically bring down the edge and bring it to the anterior aspect of tuberosity, do margin convergence there, and then do side to side more medial to that. So you got to be very careful though. U shape is really not that common.
Okay.
People are seeing a lot of U shape. They're probably overcalling, or they may be missing some other anterior L-shaped tears or reverse L-shaped tears, or even massive contracted. Because if you think about it, it makes sense that you would get a tear of the anterior aspect of the rotator cuff, so the anterior cable attachment, and it would start to pull back and over. That could be an anterior shaped tear. Okay, we got a posterior tear, and that gets you into a reverse L-shaped tear, but it doesn't often make sense to just have the supraspinatus go over and be absent. I mean, you can see that, but it's not that common. So.
Okay. So U's aren't as common, but the L's or verses. Yeah. But the crescent shaped is the most common. Is that right?
Crescent's most common, and then you'll see your L-shaped tears and your massive contracted tears.
Okay. So these
I probably see massive contracted more than L-shaped tears.
Really?
Yeah, because that crescent as it becomes larger, it spreads out uniformly and pulls over.
That would make sense. Okay. And you mentioned a little bit earlier for kind of these massive contracted tears. It seems like most of the tears we've been talking about, like the crescent, U-shaped L's, we're assuming that with just simple releases that we're able to move the tissue and pull it back to its anatomical footprint and get a good repair, with an anchor or whatever it may be. But for these massive contracted immobile tears, you mentioned a little bit earlier, doing an anterior slide. Can you again mind just kind of going through what an anterior slide is versus a posterior slide, and when you may use one versus the other?
Yeah. So anterior slide classically is described as going between the supraspinatus and the subscapularis tendon, right?
Right.
I never do that. I always do what's called an anterior slide in continuity. What that means is that you preserve the rotator cable attachment, what is known as the comma tissue that you'll see inside the shoulder, because you're trying to preserve that link between the subscapularis and the supraspinatus.
Okay.
And by doing that, you can preserve the mechanics of the shoulder, but you can still get the same effective release, because the goal of what you're doing is you're trying to release the coracohumeral ligament. And that ligament will get scarred in as you get medialization. It will get scarred in to the base of the coracoid, will scar to the undersurface of the supraspinatus tendon, and sometimes to the top of the supraspinatus tendon. So your goal of your anterior slide and continuity is to really improve that mobility. And typically you're going to get anywhere from maybe 1, sometimes 2 centimeters of increased excursion based on doing anterior slide and continuity. Now, we didn't talk on tear patterns about the subscapularis. That's a whole nother topic. But if you're doing a 3-sided release and have a big tear of say subscapularis going up to the supraspinatus tendon, by definition, if you're pretty much going to do an anterior slide and continuity to release the subscapularis tendon, because you're going to work on both sides of the subscapularis. You're going to go to the base of the coracoid, and you're typically going to go just to the top of the coracoid at about the between the 12 and the 2 o'clock position on the right shoulder, and really release the coracohumeral ligament.
Okay, so this again, this slide in this continuity or in continuity is when we're leaving some of that commissine tissue. So it's kind of that superior glenohumeral ligament. You're leaving that tissue, but you're releasing some of the other tissues between the leading edge of the supraspinatus and the subscapularis.
Exactly. And it's important to say, okay, it's harder to see if you leave it intact, but it's important because once you repair the subscapularis over, then that helps decrease tension on your supraspinatus because it's connected, right? It's just like points of fixation. More
right.
points of fixation you have in fracture setting, you have decreased resistance to failure. More points of fixation in a rotator cuff, you have decreased chance that the cuff is going to pull out. So you want to maintain that natural anatomy as best as you can.
And so say that would be useful for a reverse L, right? And so at what time do you use like kind of the double slide? Because the anterior slide and there's also a posterior slide. Yeah. Is that correct? And do you mind kind of describing what that is?
Posterior slide will work very effectively. Posterior slide, you go between the supraspinatus and the infraspinatus. Should go toward the base of the scapular spine. And both of these, by the way, what you're really doing is you are releasing the medial robust attachments of the superior capsule, because that becomes confluent anteriorly with the coracohumeral ligament, and then posteriorly it becomes very thick at the base of the scapular spine. So a lot of work's been done on the superior capsule over the last couple of years, and that's really what it comes down to, what you're really releasing. So posterior slide can be very powerful way to improve mobility of the infraspinatus and supraspinatus tendons. The downside of this, though, for me, is that you violate that rotator cable crescent complex that helps distribute the forces. So when we have that rotator cable complex, we didn't talk about it yet, but it really serves as this suspension bridge type of model where it's transmitting forces throughout the rotator cuff. So if you can get your anterior attachment down, your posterior attachment down, that's really your basis for for a partial repair, that you're restoring the force couples. Well, if you then go and do a posterior slide to improve mobility and you take down that cable crescent complex, perhaps there's a downside of doing that. So for me, I'm very cautious about doing posterior slides as a result of that. But it is a powerful way to get mobility of the rotator cuff.
Right, and I guess just to quickly go over again this rotator cable crescent complex. So the cable is kind of like that thickening of the tissue, or thickening of the cricothumeral ligament, and then that functions such as a suspension bridge. Then you have the crescent tissue, which is that thinner tissue, which actually attaches down to the tuberosity. Is that right?
Yeah, and your most important attachments are your anterior and your posterior attachments. There's a few studies that have looked at that. So people who have pseudoparalysis, or the inability to raise their arm, typically have a disruption of at least one, but oftentimes both rotator cable attachments. Or if somebody has an anterior rotator cable detachment, they're more likely to develop progression of their rotator cuff tear. It's often why anterior superior rotator cuff tears, right just posterior biceps tendon, typically are more symptomatic. You see a lot of them because actually it's just an area that causes symptoms for the patient and then goes on to progression more rapidly.
And one question I have is, so you would think that if you're doing a posterior slide and you're, I guess, releasing these tissues, in my head, I think in line with the fibers of the tendon per se, that you may be disrupting the tissues in the A to P plane, but overall, I guess firstly, just thinking about it, I think, well, you probably wouldn't be weakening it that much if you're going in the direction of the fibers of the tissue. Because when you do this, are you using a freer or something, or I would think that
Yeah, you'll go scissors and you'll just go right through it, but you'll go basically right through that posterior cable attachment to do it. So
okay, going right through.
Yeah. Now, one idea is to try to do sort of a posterior slide continuity, and I've played with that. But the difficulty there is that, so you don't take down the tendinous attachment, you go more medial. But the difficulty is that you get limited by the suprascapular nerve, because the suprascapular nerve runs right adjacent to the scapular spine. So if you're doing that blindly and can't see the nerve, then you perhaps you put that nerve at jeopardy, at risk. So
okay, all right, that makes sense. And then kind of looking or going back to some other just surgical principles, and we know a lot of times we use bone anchors now instead of, like, I guess kind of the transosseous sutures per se. I guess the standard of care for most arthroscopic rotator cuff repairs is going to be repaired using bone anchors. Is that right? Or are there some other ways that is commonly used to fix these?
Yeah, most commonly you're going to see suture anchors. There are people who talk about doing transosseous tunnels arthroscopically. Those have not gained widespread adoption just because they're more technically difficult to manage and you get limitations of bone quality. I think that they can probably work in people's hands, but the mainstay of treatment is really suture anchors because of the ease of doing those arthroscopically. They have good mechanical strength.
Okay. And can you explain I get it now, but I remember as an intern, everybody just do around double loaded, triple loaded anchors. And I didn't know what everybody was referring to, but could you kind of just quickly touch base on the difference between those, single versus double versus triple load anchors, and why you'd use one versus other?
Simply just the number of sutures you have. You might have a single loaded anchor that says one set of suture limbs. A double loaded would be 2, triple loaded would be 3. So as you increase in size, or as you increase in the number, you of course can get more points of fixation. But there are some limitations. Number one is that, for a small suture anchor, you can't necessarily easily get three sets of suture limbs, right? So you may only have a single loaded anchor if it's a very small anchor. And for instance, for some of the small glenoid anchors for Burkhart repairs. And then there's a limitation in terms of, as you move up, in terms of the practicality both in terms of what are you bringing everything down to? Because if you have a triple loaded anchor, is that actually beneficial if you bring it all to one point at the center of the anchor? There's some weight there. And then just the practicality of having 6 sets of sutures or 6 suture limbs coming out of this one anchor. So it's a balance. Most common with rotator cuff, you're looking at double loaded anchors.
Okay. Right. Yeah. Double loaded anchors. And what other, I guess, technique or technical things when you're putting in these anchors do you want to know about? I always hear about or read about the dead man's angle and things of, there's different types of anchors like metal anchors or biodegradable. Any difference between any of those?
Yeah. I mean, I think the dead man's angle issue, I think is debatable. It makes a lot of sense that you want to put an anchor in approximately 45-degree angle approach. If you just think about that, if something pulling counter to that, it does make sense. But probably the reality is that many of these anchors are going to function just fine regardless.
Okay.
In the rotator cuff environment, it's probably more important that somebody's not doing damage and seeing exactly where they're putting the anchors and placing the sutures in the correct position. I think we used to talk about metal anchors versus composite anchors. Metal anchors, downside of metal anchors is that they are not as easy to get postoperative MRI imaging on as composite or PEEK. They are also typically solid, so you have no channels that can come up to theoretically encourage healing. But then the latest really evolution is all suture-based anchors. All suture-based anchors, especially as medial row anchors, have some advantages because they are small. For instance, an all suture-based anchor might be 2.6 millimeters in size versus a hard body anchor made of polyether, ether ketone, or PEEK versus composite. Those are going to be typically for rotator cuff 5.5 millimeters in size, sometimes 4.5 millimeters in size. But you're talking about double the footprint size or double the size of the anchor, and that leads to footprint violation. And remember, you're wanting this tendon to heal the bone, right? You want it to heal back to its native surface. It's not going to heal to a foreign material. So I think there's some advantages of all suture or soft anchors in that as medial anchors in that setting.
Okay. So those, obviously they'll take out less bone space if it's, 2.1 millimeter than 4. Yeah. And those can still, again, it can always come as single, double loaded, triple loaded per se. Right. It's just the amount of sutures that are actually inside of the anchor.
Yeah. And typically when you're doing cuff, you're always double loaded and above because you want more points of fixation.
Okay. And what type of sutures are typically in these anchors, or I guess what do you use per se? Because, when I was reading this article, just to kind of prepare for this, they're talking about most of these are number 2 fiber wire type sutures. Is that something that you use in your practice, or what drives you to use one versus other?
Most of us use a poly blend suture. So there's lots of different names for this. Fiber wire is just the Arthrex name for this. Okay. But they essentially are polyester sutures that are high strength that don't stretch a lot and are really strong. But that's now evolved also into using tape-like sutures that tend to be a little bit wider. And the tape, because they're wider, they have more pull out, but more resistance to pull through in the tissue, because the weak link in rotator cuff repair, of course, is the tendon or the suture tendon interface, which the soft tissue pulls through. It's not necessarily the anchor fixation. It's the suture tendon interface. So having tapes has some advantages to pulling out. So tapes, though, can be harder to tie because they're just right. So I tend to use an anchor that has a set of tape limbs with a number 2 suture in the middle that has a knotless mechanism, so I can kind of get a combo out of that. And it's an all soft anchor. So I use what's called a self-punching knotless fiber tack anchor. That's a trade name, but it's hard to describe it without giving a trade name on that one. Right. That as my medial anchor, and then I link that out to hard body knotless lateral anchors.
And you just mentioned a knot versus knotless, and if we go to it's not the ANA meetings, but I think I was doing an arthroscopy course. They show you how to do these different knots of some sort to note that, or to just learn those techniques. But any differences between knotless versus knotted anchors, or you're throwing a knot, or what are most people doing these days, or in, I guess, to your knowledge, or
so all over the place. I think people who tie a lot of knots, they like to tie a lot of knots. I was taught by a guy who wrote a lot of papers on tying knots and what the difference is between loop security and knot security, and those are good things to read about. But quite honestly, I rarely tie knots in my practice. If you look at a couple of studies that have been done on this, one study was done by Brian Hnipsiak and Steve Burkhart, and they looked at how variable arthroscopists were at tying knots, and they took consultant surgeons, so they should be surgeons who have some knowledge base, who were at a median arthrex, and they said tie a bunch of knots, and they were all over the place,
right,
between each other and then between their own knots. And then we did a follow-up study where we looked at doing the same thing in Europe, but then compared it with knotless constructs. And the knotless constructs tend to be more predictable.
Yeah.
So assuming you have good fixation, there are some limitations of knotless constructs, but assuming you have not good fixation of the anchor and the bone, knotless, and you remove all the slack, knotless constructs tend to be more predictable, actually. So I use a lot of knotless constructs, and they're also faster, and that's nice to have time savings when you're moving in the operating room.
And that being said, so that's tying the knots. Another question I had for you is I've seen different attendings use different things. When it comes to actually putting the suture through the cuff, do you use a self-retrieving device, or do you use kind of the pink suture? I'm blanking on the name of it. But
yeah. I'm all about predictability and speed. So I use I like to have it be really efficient. So I use a antegrade suture passer, right? So I fire that suture through the rotator cuff, and it has a self-retrieving aspect for me to be able to grab it and go through. And I can use that 90% of the time. There are people who like to use suture lassos, but that's a two-step, right? You're taking a lasso, which is basically a curved device that has a hole in it, so then you can thread a wire and grab a suture and pull back out. Or you can even do ones that you can grasp with that are retrograde passing, and you take a device such as a bird beak or whatnot that has a pointed aspect that can grab the suture. I don't like those most of the time if I can avoid it, because they make bigger holes in the rotator cuff. So for me, it's antegrade passing 95% of the time for speed. Okay, that makes sense. And so we kind of already touched base on like your ideal construct. You touched base on you mostly using these double row anchors, using the polyblend suture as well, and then you also use, for the most part, the double loaded suture anchors instead of the single and triple. And the last thing that we just kind of will touch on, and that you touched on a little bit earlier, was about fixing the subscap. When, I guess, do you fix this first, and then any tips or tricks that you've learned through your time as far as fixing the subscap that is found to be pretty helpful? Yeah, I mean, I think the first thing is just really trying to understand the anatomy and look for it. You have to look, if you're going to do this inside the joint, because you can either approach a subscap intra-articular or subacromial. If you're going to approach it intra-articular, you have to look with a 70-degree arthroscope. So I have a 70-degree arthroscope up in every case, because if you don't have that, you're really not going to see down, really appreciate the footprint completely. I get a lot of people who come and observe surgery. The single most common or thing that they say is, okay, I'm seeing more subscaps than I'm seeing otherwise. Right. And if you look at the studies among high-level arthroscopists like Burkhart and LaFosse, They're there 30% of all cases, 50% of rotator cuff tears involve the subscapularis. So when somebody's saying they're seeing it 10% of the time or something, they're probably missing it. So knowing it's there, looking for it with 70-degree scope and appreciating anatomy. And then when it comes down to repair, I think you can approach these either intra-articular or subacromial. I like to stay intra-articular because I like to be viewing inside the joint and be working through other portals, versus if I move the scope up to a anterolateral portal, for instance, and I'm looking down at the subscap, I'm working very close to myself, because then I have to work anterior at the same time and I don't get to triangulate as well. So I like staying inside the joint. And you should get to them early because you tend to get more swelling in the front of the shoulder. So first thing you want to do is look for the tear. The biceps is torn to subscap. You got to get that out of the way so you can work effectively at your subscap, and then you repair your subscap as appropriate before going up. The other thing I was going to say is that that sort of along these lines is that when I do the supraspinatus and infraspinatus, as soon as I do my bony work and kind of do my initial bursal clearing, I'll go back to the 70-degree scope again. And very few people do that. But I do it at every case because it really lets me look back at the rotator cuff and look down over the side so I can really get a good assessment of that tear pattern. Because again, this is all about seeing, right? And if you can't see what you're doing, you're not going to be able to do complex arthroscopy.
Right. Okay. No, that makes perfect sense. I haven't used the 70-degree. I've seen it used once during a hip scope, but most of ours is just general standard, 30-degree scope. So I have not scoped with a 70-degree scope. At some point, I probably will. Yeah. And they always talk about, I guess, they always talk about this comma sign, and especially for us when we're taking tests, they like to just show the arthroscopic picture and make a diagnosis. For those who are listening that maybe, interns, second year, third year residents, can you kind of take us through what the comma sign is and, what the use of it is for you?
Yeah, I mean, so it's that, it's basically that medial sling of the biceps tendon, right? And that is the comma is a continuation from the supralateral border of the subscapularis tendon as that arcs up and goes to the supraspinatus tendon. And that's why I was saying it's so important to maintain that in place. But as you get retracted tears, the subscapularis pulls over, you get that common tissue effect where you use that as a way to identify the subscapularis tendon. And if you identify that common, it will always lead you down to the supralateral border of the subscapularis.
Okay. Yeah, that makes sense. Well, I think we touched on a good amount of things here. I think we covered most of the basics for understanding rotator cuff repair and the principles behind it. We talked about the rotator cable and the crescent. We talked about the different types of anchors. We talked about the different types of tears and their mobility and kind of a little bit of how to repair those. We talked about subscap tears. Anything else that you want, just our listeners listening to this to know about, or at least be conscious of when we're talking about just our, rotator cuff repairs and kind of these surgical principles? I
think we talked about the seeing things, and then other than that, I think arthroscopy has a real kind of feel to it. You just you have to really try to project in your mind where you are, and some of that is just over time, and you have to get the reps. But I think people overlook what they are feeling. I try to think about the scope of my instruments as an extension of my hands.
Right.
Obviously, they don't have tactile nerve endings on there, but you can start to get the feeling of where what your scope is hitting, what's it moving up against. And if you approach it from a feeling kind of standpoint, I think that you'll find you can move more fluidly through things. And by doing that, it'll help you kind of triangulate more as you are inserting, creating your portals of the spinal angle, et cetera.
Perfect. No, I totally agree. And I think that was a good piece of advice, is just, imagining these tools as an extension as your hands and your own fingers, and using that to be able to triangulate. Well, Dr. Denard, I think this, again, has been a great talk, great episode. Again, I learned a lot just from talking to you. And when I go back, I'll take some more notes on some of the things that you said, because I'm actually going into sports. So I'll be doing some of these. But again, I really appreciate you so much for coming on the podcast and being a guest on the Nailed It Ortho podcast.
Pleasure. Thanks for having me.